Dr. Joshua Richter, who is Associate Professor of Medicine, Multiple Myeloma Division, Tech Cancer Institute in Mount Sinai, Icahn School of Medicine in New York, United States of America. He participated in many publications and clinical trials. His presentation tonight going to be about multiple myeloma efficacy in the era of deep responses, through which he is going to present the deep response, minimal residual disease negativity, and their impact on progression-free survival and overall survival. There are a lot about this subject, especially during the AISH meeting last year. And tonight we are going to be enlightened by this talk. I would like really to welcome everybody to share his or her questions in the Q&A, please. Thank you very much, and I would like to invite Dr. Joshua Richter, and the floor is yours, please. Go ahead.
Thank you so much, Dr. Sharif. I greatly appreciate it, and thank you so much to the Society Hematology Conference and Saudi Society for Blood Disorders for inviting me to speak. This has been an amazing program so far, and I'm honored to be part of it. So today, my interest is in the deep responses of myeloma. Unlike some of our previous lecturers who are able to describe a clear pathway to curative intent, we are still not quite there for myeloma. We are getting closer bit by bit. And the way that we are approaching it is through the concept of minimal residual disease, or MRD. And minimal residual disease is a concept that has been around for more than a century, dating back to the first patient ever officially diagnosed with myeloma in the 1840s, Sarah Newberry. However, she was MRD negative when she did not have a tumor sticking out of her head. However, our technology, year after year, globally continues to improve, and we're able to detect one myeloma cell in 100, one in 1,000, one in 10,000. And we see here, as this graph goes down, that we go from complete remission to stringent complete remission to now levels of minimal residual disease negativity. And perhaps there is a functional or operational cure level by which, if we debulk enough, if we get the disease down far enough, maybe we can cure. So we know that at the time of diagnosis, most patients with myeloma have on the order of 1 × 10⁻¹² malignant cells. What is kind of awe-inspiring is that once we get to 10⁶, we do not detect any myeloma by standard criteria. However, there still remains 1 × 10⁶ malignant cells in the body. So the question is, how do we get down to these different levels of disease, and does it matter? And we know that these small changes actually have a broad impact in terms of clinical outcomes. We can see here, as we group patients who achieve MRD greater than 10⁻⁵, or in between 10⁻³ and -5, or less than -3, we see a significant difference in impact in median survival from 27 months all the way up to 80 months. We can actually see in this wonderful publication by Rostron et al. A number of years ago that each log reduction in minimal residual disease achievement, you go from MRD to 10⁻³, 4, 5, and so on, he correlated an approximate 1-year improvement in median overall survival. So this is really the way we are approaching the disease in 2022. Now, how do we measure MRD? And there are a variety of ways that we can, including things like imaging, MRI, CT, and PET scan. However, most of these are still bone marrow-based assessments. And despite the fact that there are many of them, including PCR-based tests, CyTOF, and mass spec, the 2 leading technologies at the moment are next-generation flow cytometry, or NGF, and next-generation sequencing, NGS. Now, at the moment, NGF is more ubiquitous. As the last speaker mentioned, flow cytometry is available at many institutions, and this is simply a multicolor parametric flow that we can run. It is very ubiquitous, it is easy to run. The problem is, although plasma cells in the bone marrow are almost impossible to kill, they crumble and fall apart in the flow cytometer. So if we send cells down the flow cytometer and we have 0 on the other end, denoting MRD negativity, where there's 0 that were sent in, or were 3 sent in but didn't make it through the machinery. So although this test is easy to run, it's very ubiquitous, there's a potential for false negative. Next generation sequencing is a bit more sensitive, really approaching 10 to the -6. It is still bone marrow based only, at least in the US, it's only run by one company, so it's not run by everyone. You also need a baseline sample to find a specific clone, meaning if someone travels all over the world and then they show up in your clinic, you could send MRD by next generation flow. Doesn't matter if you've never seen the patient before. But NGS requires a baseline sample to identify a molecular signature to look for it later. And about 5 to 10% of patients will not have a unique molecular signature, so it's not as ubiquitous as next generation flow. Now, again, what really matters to us is the applicability to patients. So this is a multi-step process. And really the reason why this is important is that this does appear, at least at the moment, to be a superior technology. And this is all about long-term planning. I saw a patient in clinic last week, and we're doing MRD ID sample now, not because we are intending to test for it immediately, but once you have this banked, you can look for MRD at any point in the future. So it's very important, at least now, to achieve that 10 to the -6 level of resolution to have that baseline ID sample. So not only are we doing this on all of our patients now, but we're looking at our archival samples over the last few years and just brute force obtaining MRD identification on all of them so that we can use this technology moving forward. Now, this is crucial because although rates of MRD negativity in the upfront studies are quite high, in fact, looking at the Griffin study, DARA RVD, they achieved an MRD negativity rate of 52%. The reality is that the ability to achieve these deep responses drops line by line, and studies have shown that the majority of patients don't go beyond 3 or 4 lines of therapy, despite the availability of a dozen different therapies, 2 CAR-Ts now approved, and new bispecifics on the way. We only have a discrete number of times to make interventions, to come up with a plan of care to attempt to achieve MRD negativity, because we have shown that at every point, from early to late, the deeper response correlates to the durability of that response. Now, it's interesting because for years we have been using CR, complete remission, as our line in the sand, and we recognize that you can have complete remission MRD positive, less than a complete remission MRD positive, all the different combinations. And CR alone is not the end-all be-all of determining outcome in myeloma. In fact, it seems that MRD supersedes any type of CR evaluation, and really because CR is still a cruder way of evaluating the depth of response, and because of the heterogeneity within the marrow, as compared to many other hematologic malignancies, simply looking at a few fields with immunohistochemistry for CR evaluation may not be enough. And we know that despite whether or not you've achieved CR or haven't, MRD supersedes that in terms of your clinical outcomes. Now, here's a list of retrospective analysis of patients, all of which achieve CR. In a generation ago, we would have said these people are all on equal playing field. They have no measurable myeloma in the marrow. And we see here now running them and evaluating between those that are CR and MRD negative versus CR and MRD positive. And the difference in time to progression, 35 months versus 131 months. We're not talking about a minor difference here. We're not talking about a few months. This is a dramatic difference. And these are the patients that have achieved CR, and then we scratch our heads saying, but you're in CR, why are you relapsing so quick? So we really need to enhance the ubiquitous nature of MRD testing to get better prognostics at the bedside. And interestingly enough, if you look at all of these in a retrospective analysis, MRD negative versus MRD positive, it looks like the CRs actually behave, or the MRD positives behave like PRs. So there's less and less a difference between PR, VGPR, and the classical responses if you're MRD positive. The MRD negatives have a completely different and much more profound outcome. What's above and beyond this is that we always like to say that myeloma is a movie, it is not a snapshot. So what's crucial about MRD analysis is that it's not done at one point in time. In fact, we define sustained MRD negative as 2 marrows done at least 12 months apart both being negative. If you achieve both as being MRD negative in any setting, your outcome is going to be vastly superior. Now, we recognize that it improves the duration of remission. And again, whether or not this is upfront myeloma, relapsed, heavily relapsed, the deeper response, the better you do. And much of this comes from the subclonal nature of myeloma, is that at the time of diagnosis, most patients already have 4 to 6 subclones of disease, and we really need multi-agent regimens with different mechanisms of action to exploit each individual clone and to have the synergy of those MOAs kill even more clones. The more clones you kill, the deeper your remission. The deeper your remission, as we can see here across the board, the more durable remission. And again, the same holds true even for patients who we've defined as complete remission. Remember, a generation ago, all of these patients with these diverging curves would have been viewed as universally the same, as of achieving an unbelievably deep remission. But we know we can do better. What is the future of MRD testing? The future of MRD testing is mostly blood-based. There is some wonderful work being done right now on using some of these technologies so that we don't have to do a bone marrow every time. And some of them are the standard ones we already have, running next generation flow in the blood or running next generation sequencing. However, there are several newer technologies which may supplant this in the coming years. One of them is mass spectrometry, which is really being used quite heavily at the Mayo Clinic and may be a pathway to identifying small levels of disease. And the benefit of mass spec is that as we use more and more monoclonal antibodies, with the majority of them being IgG kappa, the mass spec can tell the difference between a small amount of circulating monoclonal antibody and a small amount of myeloma. Soluble BCMA is another technology which is coming along very quickly, and especially in a realm where we have many new anti-BCMA therapies, this may be optimal. It's one test that works regardless of your phenotype. So soluble BCMA is there whether or not you're IgG or IgA. It is secreted even in non-secretory patients. So the patients that were not able to measure a paraprotein by free light chain analysis or M-spike can be measured by soluble BCMA. More importantly, soluble BCMA has a half-life of about 24 hours. The current standard is to give chemotherapy for at least a month or two to see if the patient is responding. But with a half-life of 24 hours, you could, on a Monday, give somebody a treatment, and on Thursday or Friday, already know if it is working or not, sparing the patient unnecessary treatment. So does it matter how sensitive? Yes. The more sensitive our technology, 10 to the minus 4, 5, 6, the deeper it is, the more this correlates with improvements in progression-free survival, the more it improves with overall survival. What about for the different technologies? Well, essentially, all the technologies, yes, there are some better pieces of one, better of the other, but overall, regardless of what technology, if at this moment, if you're able to demonstrate MRD negativity from any way, your patients will generally do better. MFC or multicolor parametric flow is not quite as good as the next generation flow, so it's not quite as good, but it does overlap. And again, does it matter? Newly diagnosed transplant eligible, newly diagnosed transplant ineligible, or relapse? Regardless of the setting you're in, MRD negativity improves overall outcomes. So wanting to tie this in with the IKEMA study, and the IKEMA study is a wonderful head-to-head study that was done for patients with early relapsed myeloma, which we define as 1 to 3 prior lines of therapy. And it was a head-to-head study of Kyprolis and dexamethasone, carfilzomib and dexamethasone, versus isatuximab, Kyprolis, carfilzomib and dexamethasone. The patients were randomized in a 3-to-2 fashion. They were treated until disease progression or unacceptable toxicities, and the schema can be seen here as we had administered it. Now, the first endpoints that we look at are basic response endpoints. The overall response rate was 87% compared with 83%. It's improved, but it is not night and day. So at first look, you say, yes, the triplet is better, but it's really when you get to the granularity of it that we understand how much better this really is. In terms of progression-free survival, the current PFS for KD is 19.15 months. The median progression-free survival for ISA-KD at the most recent data cut has not yet been reached. And part of the reason for this is that overall response is just the first step. When you look underneath it, what are the depths of those responses? And with the triplet, with ISA-KD, we see more CRs, more MRD negatives. And those are the patients with the really, really long remissions, which is leading to the tail on this curve. So it's all about, in my ways, winning the lottery, right? We don't necessarily know upfront who is going to be of that subgroup, but we want more people to be in that subgroup, which is why the triplet is the better way to go. Now, in the US and in many other places, lenalidomide represents one of the early approaches. Lenalidomide is part of many upfront strategies in the US. Ex-US thalidomide tends to be used first and lenalidomide as a second-line therapy. But now that we use lenalidomide in early lines, we are constantly looking for non-lenalidomide-based regimens in the early relapse. And here's a listing of the key clinical trials or the key phase 3 trials that looked in relapse refractory myeloma without a lenalidomide backbone. And we see a variety of outcomes here, both from bortezomib-based regimens like Optimism, Boston, and Castor, to carfilzomib-based regimens like Endeavor, Candor, and Ikema. And we look and we see the two standouts. One is the Bellini trial that seems to have an extremely long remission, but we have to remember that there's been a lot of issues with the venetoclax, and venetoclax is an extremely potent drug, especially for 11-14 translocated myeloma. However, patient selection here is key to avoid potential toxicities. But all the way on the right, we see the Ikema study with unbelievably long remissions. And part of the reason for this really superior PFS is the ability to put more people into the bucket of MRD negativity. So we look here at just at the rate of 10 to the minus 5, and we see an MRD rate essentially doubled, more than doubled, of ESA KD over KD, whether it's in the CR group only or in the intention to treat population. When we look at the general flow of responses and the depth of response, there is a very different curve, both speed and depth, comparing ESA KD to KD. So not only do you achieve more deeper responses, you achieve more deeper responses quickly and get them out of trouble. When we think about the people who achieve MRD, trying to pick out, can we predict ahead of time who is going to be in that subgroup? Oh, apologies. So one of the things that we see is really coming into light a lot is the notion of 1Q gain. For many years, we have typically described high-risk cytogenetics of things like 17p deletion, 1416, but in recent years, we've began to understand that 1Q gain, especially the more copies you have. So 3 copies is bad, 4 is worse, 6 is worse. We're starting to learn that the 1Q population of myeloma may in fact be one of, if not the worst behaving group. Anecdotally, they have tons of extramedullary disease, very recalcitrant to therapy. And we see that even in this study, the 1Qs had the same amount of MRD negativity. So classically, we think that high risk is difficult or more difficult to achieve these deep responses. But with a complex regimen like this or an aggressive regimen like this, we may be able to overcome some of that. Now, again, no matter how you achieve your MRD negativity status, you do better MRD negative versus MRD positive. The question is simply more people in that bucket with the triplet over the doublet. If you had prior transplant, you tended to do better. And again, this just really enforces that transplant is still an absolute standard in the management of myeloma, both from an outcome and an economic standpoint. It really does do well for people. There are, of course, a subset of people that probably no longer need it, but I fall in the camp to say, a 15-minute infusion can buy some people a decade. But there's some bias here, of course, because the people who are young enough and fit enough to undergo autologous stem cell transplant were going to do better. But again, either way, patients improved with the triplet. In terms of prior lines, remember that we looked at this across 1 prior line, 2 prior lines, 3 prior lines. The subgroup analysis holds true for the triplet over the doublet, regardless of 1, 2, or 3 prior lines of therapy. The same thing based on refractory status. Whether or not you were refractory to lenalidomide, the ESA-KD regimen was superior to KD regimen across all spectra of response from ORR, VGPR better, CR, or MRD negativity. The same is true for bortezomib refractory disease across the board. We see an improvement of the triplet over the doublet. Cytogenetic risk, again, this is a tough and an expanding issue, especially with the notion that we may need regimens like this to help overcome some high risk. And we see here that, of course, standard risk, we have better 36 versus 11.7% MRD negativity. But I asked you to focus in the middle on the gain 1Q, 32% rate. The reality is these are some of our worst players in myeloma were able to achieve very deep responses. And again, noting that in myeloma, the average age is around 69 to 70. The question is, when we have an amazing regimen like this, is it equally applicable for our older and potentially frailer patients? And the answer is yes. Regardless of age category in this group, we saw the same pattern of improvements in depth of response, percentage of response with ESA KD over KD. And as a final slide, we recognize that depth of remission correlates to the durability. And this is key because we only have 2 or 3 or maybe 4 interventions for your average patient to achieve a deep remission, which means put your best drugs forward, your best in class CD38, your best in class proteasome inhibitor. You move them up to achieve deep remissions early. MRD negativity is still the gold standard for measuring this. And we really want to make sure we're achieving this early, where the disease is less refractory, the patients are young and healthy, and we're able to achieve this. What is the future of MRD? As we learn more, we may be able to understand if you achieve sustained MRD negativity, maybe you don't need a transplant. Maybe you can stop your maintenance therapy. This is evolving. The benefit of MRD is that the regulatory institutions will maybe start to adopt this as a primary endpoint, to allow shorter times to achieve data on clinical trials, to get drugs in the hands of our patients sooner. And again, at the moment where many of our CD38s are given with IMiDs like lenalidomide or pomalidomide, there is rising data to support anti-CD38 with carfilzomib, either ESA-KD or DARA-KD, with so far the ESA-KD data being amazing. And with that, I would like to thank you so much for inviting me to speak today.
Thank you very much, Dr. Richter, for this clear talk about minimal residual disease. However, we do have many questions actually about minimal residual disease. For example, so far as we understanding that multiple myeloma cannot be say that one disease. It might be 8, 10, 14 types of diseases. And as we see that sometimes those patients, they don't have high-risk myeloma, they will relapse early after the treatment. This is going to be also applied when we are using minimal residual disease, that it will be negative, but later on the patient will relapse early? Or how can we use this good thing that in the top our patients, especially high-risk patient?
So I think there's a few things. One is, I think over time, exactly as you said, there are many types of myeloma. At one point, we may be as sophisticated as the lymphoma docs to know that there is myeloma that is a CLL-like phenotype that cannot be cured and needs chronic therapy, or maybe diffuse large B, there are curable phenotypes. The other, which I did not talk about, is the nature of that MRD positive patient. There is some brilliant ongoing work, a lot done by Bruno Paiva, looking at converting patients to an MGUS-like state. So what's important is not just getting the patients down, but those few cells that are left, what is their biology and their nature? Because if we can get not everyone down to negative, but we can convert some people back to an MGUS where they may never progress again, then we don't need it. So I think the biggest leap forward in the next few years is not just going to be drugs, but better understanding of the T cell and immune repertoires and the microenvironment support to know what's left over at the end of any treatment.
Dr. Fahad, if you allow me, may I ask a question here?
Yeah, please go ahead.
So thanks for the talk, Prof. Richter. So now you mentioned a very valid point, which is using different techniques now for MRD assessment. The thing is, with doing a bone marrow MRD, we are just assessing the bone marrow, and we know we medullary myeloma, and we see that sometimes patients, they achieve MRD with bone marrow, but they are still in PR or just VGPR, which means that this paraprotein most likely coming from outside the bone marrow. So that's why we need a tool that thoroughly assess the patient, not only the bone marrow. It looks also at the extramedullary. PET-CT was used to assess MRD status in patients with myeloma, but with some caveat, because myeloma is not like Hodgkin, so the uptake of the FDG in myeloma patients is not similar to Hodgkin disease. So that's one thing, assessment of the extramedullary myeloma. And the other thing that also I think we are still missing in myeloma field is MRD adaptive approach. There are some studies looking at that, like the MASTER trial, for example. And I think that's one thing we are still working on is, okay, how to use that piece of information to adapt my therapy, to either escalate or de-escalate, to go for transplant or not to go for transplant based on the achievement of MRD status. Thank you so much.
I could not agree more with you. You are 100% correct. Especially with the Dr. Costa presenting the master trial, I think that is an amazing step forward when we have that data. For the other part, agreed. We need multimodality assessments. So we try to do concomitant imaging and bone marrow. One of the interesting things, though, is that the classical descriptions of PR, VGPR measure the paraprotein, while the MRD status measures the tumor type. And one of the things that we've seen, especially in the CAR T world, is that given the fact that the half-life of the intact immunoglobulin is 1 month, you give someone a CAR T on day 0, and let's say they have an M spike of 6 grams. Then a month later, all the cells in the marrow are down, so they're MRD negative. But the paraprotein, that IgG kappa they make, has still not cleared the body. They may be PR and MRD negative simply from lack of clearance of the paraprotein. So that's one issue that needs to be resolved. The other one that you talked about is absolutely critical. We have patients that the disease decides it does not want to grow in the marrow. It loses CD56, it grows anywhere in the body. So I have a patient last week who has tumors everywhere, the marrow has nothing. So I think your approach is perfect. We need multimodality assessments for MRD at multiple points, and in the future, knowing who still needs more aggressive, who needs escalation, and who needs de-escalation.
Okay, I have a question about if we shall ask when it is going to be that minimal residual disease as a standard in the management of multiple myeloma, because so far there are the new trials should include minimal residual disease, but however, so far it is not yet confirmed to be a very good tool in the hands of the practitioner.
Yeah, I think we have a lot of ways to go. I think that, for us, part of this is, every time we make a leap, we lose a little bit of fidelity. So we know overall survival is the standard. Progression-free survival is a surrogate, but not a perfect one. MRD negativity rate as a surrogate for PFS, is a surrogate for OS. There is some fidelity loss. For us, the big issue is to continue to press, at least, I don't know, I can't comment in many parts of the world, but in the US with the FDA, we have to convince them that this is a valid endpoint, because nobody wants to run a trial for hundreds of millions of dollars that the endpoint is not going to be accepted for FDA approval. So a lot of this is continuing to run the validation studies and coming up with enough backing to support the fidelity where the FDA will say, you know what, this is a good enough surrogate. So instead of waiting 10, 20 years for overall survival, or upfront therapies, the median progression-free survival on upfront, 5, 6+ years, that's too long to wait for this to read out. We need to continue to gather evidence to convince them. And once they are accepting this more, then we can have these full trials. I think the trial that was mentioned, the master trial, is a great foray into this. It is specifically driven. If you're MRD negative, you can stop, and MRD positive to continue. I still think it's a number of years off until it's going to be the standard.
Okay, thank you. Is there any more questions, please? So the other problem that it is not yet available in even sometimes in big centers treating multiple myeloma. And for example, in our center, really at King Faisal Specialist Hospital, I tried many times to push the hematopathology department to approve it, but unfortunately, so far it is not yet available.
Yeah, I mean, listen, I work in one of the largest myeloma centers in the US, and we still send out our MRD because the next generation sequencing is only run by one company. So we send that to Adaptive Biotechnologies. And our flow cytometers, even though they have the capacity to do it, they do not want to dedicate that type of machinery. So we actually send ours to Mayo Clinic laboratories. And I think a lot of people still do because I guarantee that you have the technology in that great institution. It's just a question of somebody getting the everything set up, the validation, getting the software and everything that's needed. But until that's set up, we are still sending ours out as well.
Okay, thank you